So welcome to the VTE Specialist Network session this morning. Thank you very much to Joe, Jerome and Thrombosis UK for inviting us to do this session this morning. The VTE Specialist Network is a network of around, I think about 120, 130 specialist nurses, pharmacists and AHPs who all have an interest in thrombosis and anticoagulation. And we meet regularly and work very closely together collaboratively to share resources and expertise and ideas. So when thinking about today's session, we wanted to do something a little bit different. We have a platform where we are able to communicate with each other and chat. And one of the themes that was coming through on that was around the impact and the difficulties in implementing new electronic systems, which it feels like we are all having to do now. They're huge projects and have a massive impact on our workload and impact on our patients. So we thought it'd be really useful to do a session this morning to talk a bit about our experiences with that and hopefully to give some hints and tips and also to think about the impact on anticoagulation and VTE prevention. So I'm Emma G. I'm a nurse consultant in thrombosis and coagulation at King's College Hospital, and I chair the VTE Specialist Network. And I'm joined by some colleagues today. I've got two colleagues from the VTE Specialist Network, Becky Simpson and Claire Gibson. And Becky Simpson works at Ashford and St Peter's and is the co-vice chair of the VSN, and Claire Gibson works at the Princess Alexandra Hospital and is the secretary of the VSN. I'm also joined by Ros Byrne, who's just out of picture. There you go, here she is, here on site at King's. She is the lead pharmacist for anticoagulation here, and she will be joining me in the second half of our session today to talk about warfarin management and going back to basics a little bit on that. Again, something that we hoped would be quite useful for you. So you're very, very welcome, as Joe said, to put any questions you've got. You can use the Q&A button there. Also, if you want to talk to other colleagues, it can be useful to talk in the chat. So we're going to get going. I'm going to share my slides for the first talk. Implementation of integrated electronic systems. Now, sometimes this takes me a couple of goes to get it on the right screen for me for some strange reason. Yeah, now I've got two screens. How's that?
We can see the slides down the side.
Okay, I thought as much. Let me try one more time, and if it doesn't work, then we'll just go with that. Okay. Hopefully you can see the right slides now.
Yes, perfect.
Wonderful. Great, thank you. So I'm going to hand over to Claire Gibson, who's going to start off this session.
Thanks, Emma. So, as Emma said, this is a quite unusual sort of topic for us, and I'd just like to state from the outset that none of us are experts. So we're coming at it from a point of view as kind of the end user and our experiences, but we thought it would be really helpful to get your thoughts on it afterwards, those that have gone through this process, but also maybe it will be of some use to those of you that have yet to go through it. And to put it in context, back in 2019, as part of the NHS long-term plan, digitally enabled care will go mainstream across the NHS. And the frontline digitalisation programme landed in 2021 with the aim of getting EPR into every NHS trust by March 2025. And currently, as published by NHS England Board in March this year, 96% of trusts will have implemented their EPR by March 26. So we've only got 9 trusts, which is 4%, who are in process, according to that paper. And the evidence suggests that digitally mature trusts are approximately 30% more efficient than their less digitally mature peers. those efficiencies can vary, of course. They quote about 17.5% reduction in sepsis and about 4.5% reduction in length of stay as examples. But obviously, there's a downside, and it's also been reported that implementation is associated with an increased risking to patient, or increase in the patient safety incidents in some hospitals. That was actually our experience as well when we went live in 2020, in November 24, so relatively recently. And in April, the Health Foundation recently published an excellent article that certainly resonated with me after some of our experiences immediately post go live. And really in terms of perhaps there needs to be a strategy to realise the full potential of these systems. Next slide, Emma, please. So at the very start of the process, we all hear an enormous amount about the benefits of the new system that we're all going to get. Some are listed here. And they're obviously considerable increase in efficiency, as we mentioned, and it's easier for the user, in theory, access to high quality data, reduction in errors. And at my hospital, one of the benefits realization pieces was actually VTE. But the reality is that post go live, most of us experience significant drawbacks, not least the stress involved, and we do see increased errors. We have data migration issues, access to reports that maybe were there before. And of course, we can see a significant downturn in the VTE risk assessment compliance. Becky's going to talk about that in the next few slides, but we've also seen significant problems with our warfarin prescribing and administration, and these have led to errors and an increased burden on the EPMA team. So whilst many of us are already using a new system, we did think it would be useful to share some of our thoughts about things that you might like to consider in the planning phase. Next slide, Emma, please. So one of the main things really is that to get involved really, really early, reach out to those in charge. And it's really important to understand and map your current processes and understanding your future state priorities. What do you want from the system? What would be your ideal? You need to be prepared for significant change. You need to get the staff on board and really help them understand the scale of it. That was one thing that came through from our experiences, that staff just didn't really comprehend how big this was going to be and how it would impact their working. I think we need to learn about the system as much as we can. We had a great deal of difficulty with this. We were asked to make decisions regarding what we wanted without actually understanding what the system could do, but what its functionality was, particularly around the VTE work and the warfarin prescribing. And it seemed a very back to front approach to us, and we didn't really know what we were doing when we were trying to say what we wanted, because we didn't know what its functionality was. So I think reaching out to other users is really, really important. And just bear in mind that if you do have the same provider, you might not actually have the same version of the software, and so you get there's a hierarchy in functionality. Engage your staff, inform the patients, so communication is absolutely key. Engage with your subject matter experts and allow them time to attend sessions. The training needs to be planned really carefully, and also to release your staff so that they can attend those sessions. It's one of the things they thought that they did quite well here. They had a target of getting 90% of all staff trained by go live, and they actually got to 95%. But actually the training itself was flawed in areas and certainly could have been improved. So looking at that is incredibly important beforehand. I think ensuring your housekeeping is in order, so you're really understanding what you had, what you currently have. And also, I think it's very important to let people know that you may not be actually replicating the best things from your previous system in the new system. So that's something that maybe we can talk about. I don't know, Emma, whether you or Becky, what you think about that, but certainly we had some really good processes in place and they weren't replicated when we went live.
Yeah, I think setting those expectations is important, because I think with a new system, there is the assumption that it's going to be better than what you had before. And of course, they all work in very different ways. And sometimes the systems, even though they're very sophisticated, can't necessarily replicate what you had before and how you worked. And so I think setting those expectations that things will need to be done differently. Some things may work better, some things may not work as well as you previously had it. Over time, though, I think generally speaking, you do develop ways to use the new system to work well with your processes. But yeah, I think it can be frustrating and it can be disappointing as well, can't it?
Yeah, so I think it's hindsight's a great thing. But if you consider, if all of these things are considered prior to implementation in that planning phase, then, you know, hopefully there wouldn't be any nasty surprises. So I think next slide, please. I think that's you next, Emma.
Yeah, so Claire's pointed out some of the really important steps in planning. And I think, certainly at King's, we implemented Epic about 18 months ago now, and we spent a good 18 months, 2 years in the planning. But actually, I think what became clear was that you can't ever really plan enough for it. And at some point, you just have to launch. And what we found, what we learned from that sort of go live phase was that was setting the expectations for that and trying to reduce the clinical workload as much as possible during that time. Give yourself the best chance of success as possible by reducing annual leave, trying to create a very calm atmosphere in your teams as much as possible. I think identifying those people who are very digitally able and therefore able to support others, able to create cheat sheets and summaries very quickly because they're able to grasp it very, very quickly, is really key. And we really leaned on those people a lot. I'm not one of them, as you could probably tell with my attempts to share my slides. Accessing the support and I think understanding ahead of go live who you're going to be able to access on the day when all of a sudden you can't do something that you need to do for patients. And at the top of that list was communicating with patients, because they will be impacted, they will feel it. Things will be going wrong for days, weeks, maybe months following implementation. And obviously that needs to happen at trust level, but locally in your teams as well, it's a good idea if you can do to try to communicate with them beforehand and set their expectations. Normalize frustration. It's extremely frustrating when you can't do what you want to do, or everything that you want to do takes 4 times as long as it normally would, and support each other with that. And I think regularly thinking about getting together to debrief, to let off a bit of steam, but also to look at what the issues are and to be able to prioritize those in terms of safety first, and then efficiency as well, and try to escalate those. There should be processes in place that you can escalate those concerns as well. But yeah, we found that there was a lot of fatigue and a lot of frustration. So supporting each other and just sort of being, as kind and as helpful to each other as possible was how we got through it, I think. After implementation, I think Claire's already mentioned the benefits realization, which I think is so important, because it's a huge upheaval for clinical staff to go through this, and an awful lot of time was spent in the planning phase and then subsequently. And so I think it's really important that you do feel like there are some benefits, and really identifying what those benefits are and the impact that they have on patient care is very important, and to sort of disseminate that learning. Thinking as well about how the system needs to be improved going forwards. It will never be the finished item when it is launched. And therefore, it isn't really until you're physically using it day in, day out that you can really identify and then articulate the little tweaks that you need in the system. And again, that can be a little frustrating because, of course, everybody wants their change made straight away. And there are often delays in that kind of process, which can be a little frustrating, which, like I said, is why it needs to be thought about which the clinical priorities and the efficiency priorities are. I think having a chance to sort of play around a little bit with the system is really useful. Obviously, we want to quickly understand the pathways within the system that will enable us to do our job. And so we quickly learn those. But then, and again, this is where the more digitally able people really come into their own, in that people who are, you know, a little bit more confident maybe to click around can find different shortcuts, different ways of doing things that can then be shared with the rest of the team and are really helpful. Thinking about use of quality improvement projects to target those improvements, to do it in a structured way, I think is very helpful as well. And also that helps to manage expectations and time as well. We found that there was a lot of feedback in the team of the frustrations, and so trying to sort of get people to understand that we were a little bit gridlocked in that we just had to wait until the support was there for us, was a little bit difficult. And that optimization does require resource. Some of that, like I say, can be done locally, but some of it you will need help from the IT company or your internal IT systems with. Now, Becky's going to talk a little bit more about VTE risk assessment in new systems.
Hi. Hello, everyone. Thank you for joining us. This is just going to be a very concise overview of integrating the electronic VTE risk assessment, kind of areas that are brilliant, areas that can sometimes be a drawback, and then being able to optimise those for the best management of our patients. And it's going to touch on some of the themes that Claire and Emma have already drawn out around this topic. VTE risk assessment is always going to be a major topic when you're looking at designing and implementing in your EPR systems. It's an essential fundamental part of care that's required for all the adult inpatients. So it's a big thing, and it will always come as a priority piece when these systems are being designed. But when we're thinking about the use of the VTE risk assessment, there's some great things about it, because it will provide some form of standardization and reduce some of the variability between the way that risk assessments are completed and used. It does add in a nice little bit of automation, which evidence does tell us reduces some human error and missed assessments, but there are some caveats to that, which we will go on to on the next slide. Also, it does provide some really nice real-time prompts that can help with that clinical decision making and help support those clinical decisions, particularly around dosing in special populations. And you've got a nice bit of tracking, so that you can do a nice bit of auditing, keep an eye on your compliance, and look at how well those risk assessments are being completed or not, depending on what's happening at the time. Some cons that we found in our experience, and I think both Emma and Claire have touched on this, is there is a major risk of alert fatigue. And it almost becomes indoctrinated, and as a system you then become completely reliant on prompts in order to complete all of the tasks on the system. That can be really, really draining as an end user for clinicians that are trying to complete the risk assessments, and also for anyone trying to view the risk assessments, because you go into a system, you try and complete something, and you've got all of these things coming up that you just don't even look at. You just try and click them and get rid of them in order to do the task that you're trying to do. So that's something to be aware of, and we will think about that when we're talking about optimization. You need to really think about how you're going to integrate the risk assessment into the workflow, and if it isn't integrated properly, that can cause an issue with compliance and with actually the validity of the risk assessment completion, particularly when the risk assessment can be bypassed. And also, if it's not implemented very well, you do have an issue with data quality. So if we can go on to the next slide, please, and we're thinking about optimization. So when we're thinking about embedding it into the clinical workflow, there's a couple of things here, and there were a huge piece that came through at Ashford and St Peters when we were thinking about this. You're thinking about where the risk assessment is going to appear in your workflow, and that then leads into the question, are you mandatory versus non-mandatory? So are you going to make the risk assessment a mandatory field on the system, or are you not? And within those two questions, there are lots of little kind of sub questions. So if you do make it mandatory, are you going to have it mandatory with a hard stop? Are you going to have it mandatory with a hard stop and a link to prescribing? Are you going to have it mandatory without a hard stop, but also linked to prescribing? There's lots of different ways you can do that, and there's no correct answer. It's a bit kind of an evolving system, as Emma alluded to earlier. As you start using the system and you start getting the feedback from your colleagues and the end users, you will be able to tailor that to make it more user-friendly. So when we first went live in the midst of a global pandemic, so it wasn't ideal. And the VTE risk assessment triggered every time somebody entered a patient record. So you could just be entering the record to try and look up a blood result before you went to clerk a patient, and you would be faced with the VTE risk assessment, which wasn't the appropriate place because you didn't have the information, you hadn't seen the patient, so you wouldn't be completing the risk assessment. And so everybody just override it. And when it was overridden, you get all of these VTE risk assessments down the side in the documentation tab. So it looked like the patient had 50 VTE risk assessments completed. So then nobody actually went back and did it because it looked like it had been done because there were all of these recorded VTE risk assessments. So where you embed it in the system is really, really important. And we're now 3 years further on and following feedback, lots of feedback sessions, which is really, really important from the clinicians. We now have the VTE risk assessment within the workflow, and it triggers when someone goes to first prescribe for a patient. The feedback from the system users has been great. They all love that because they've done the clerking. They can complete the VTE risk assessment with all the information and go straight into prescribing the prophylaxis. But that has taken a few years to evolve that. So it's never going to be perfect when you first launch. You have to work it and evolve it and get it ready for you. And that then leads on to, do you have it as an add-on? Evidence tells us that's probably not a good idea when you're looking at all the research around electronic forms and electronic alerts. For us, we had a period of 3 months where our risk assessment prompt and alert was turned off. So it wasn't mandatory, and the VTE risk assessment became an add-on. That was not recommended nor endorsed by the Thorn Braces team, I would like to add. When that happened, our VTE risk assessment completion rate actually dropped from 97% to 56%. It was quite dramatic. And the reason that decision was made was because there was so much pop-up fatigue. And that was felt that would help with the pop-up fatigue. But actually what it did do is caused major patient safety issues for us. When we reinstated the risk assessment as part of the workflow and as mandatory, we then went back up to 99, 100%. So just things to consider when you're thinking about how you're going to embed the risk assessment into the workflow. Another thing to consider is the use of smart logic. I remember when that was first mentioned to me, when the system was being designed, I had to do a quick Google. Had a bit of Google help because I didn't know what smart logic was. Smart logic in the context of VTE risk assessment it kind of refers to automated decision making. So you can set it up whereby if a patient has a risk factor, a thrombotic risk factor, the system will automatically, at the end of it, give you an outcome that you need to prescribe prophylaxis, and then it will move you into the prescribing phase. Or you can have it set up that if their patient has active bleeding, that it will suppress the prescribing of anticoagulation. So there's lots of different things you can do with that smart logic. It's really clever. Not all systems have it, but if you do have it, it's a really good function to make sure that you utilise appropriately within the build of your form. And there are a lot of benefits to that because it reduces unnecessary steps. It can improve accuracy and safety. It does save time for clinicians, but that's all with the caveat that all of these things are reliant on the information that is inputted. So if the information that the person that's completed the risk assessment isn't that accurate, you're not necessarily going to get an accurate outcome on the risk assessment. And I think that's really important to be aware of with all of these electronic systems. They are only as good as the information that is being inputted into them, which is really, really important to make it as simple and easy and user-friendly as possible. And then Education and audit feedback is really, really important. I think Emma and Claire have already spoken about that and drawn out those themes. It's really, really important to get the feedback from your colleagues that are using the system and use that to inform any changes or any evolution of the forms and the systems that you're using, so that you can regularly review if they're effective and then update them as necessary. I don't know if that's covered any of the experiences that Claire and Emma have had, or if they would disagree with anything I've said there.
No, it's challenging, and it's a bit of an iterative process, I think, isn't it? It's not necessarily, unfortunately, right first time, but yeah, no, I think you've done a good job of illustrating that. Thanks, Becky.
Yeah, and I think, Becky, I mean, our figures were mirroring yours, so it's a shame, isn't it, that there isn't a bit more sharing around that things. That it's like reinventing the wheel still, isn't it? We're all doing the same things, we have the same problems, and you know, you and I have spoken about it, and I'm trying to learn from you and your experiences. So it would be nice maybe if people could put in the chat if anyone hasn't seen a downturn in their VTE risk assessment compliance post go live to a new EPR. That would be quite interesting. Or is literally everyone having the same issues? So I mean, for those of us been through this process, it can be extremely painful, and it would be really nice to know whether you agree with this statement that was recently published from the Health Foundation about the need to have a strategy to capitalise on the potential of these systems. But also for us, it's so relevant because there's a huge potential for us to improve VTE prevention. It has been really difficult, but the potential is there. Even though we've seen those downturns over the next few years, hopefully we're all going to get our systems working to a way that we can optimize VTE prevention. So as part from also sharing our experiences and successful projects, we should be able to improve our data quality. We should be able to get more sophisticated reports to target areas for improvement at local level. The system should be enabling us to reach our 14-hour NICE quality standard around thromboprophylaxis. And our risk assessments should actually become more accurate. We know there's always a problem with not only getting them filled in, but getting them filled in accurately. But your system design should be enabling that for clinicians, like Becky was saying, rather than hindering them. And they should have access to the clinical information that they need more readily in order to complete that accurately. If prompts and alerts are used correctly, it can improve patient safety. We should be able to improve coding, which should help us in the investigation and prevention of our HATs. We should be able to join up with other systems as well to improve patient access to education on VTE prevention, the signs and symptoms of VTE. We should be able to add digital information to discharge summaries. I know that's happening in lots of places. And so there is a huge potential, but it's not easy, and it will take time. So that's my kind of take on it. I don't know if anyone else has got anything to add.
Sorry, I was on mute. No, I think that's provided a really nice summary, and we have got one question. Thank you, Sue, for your comment. Watch this space. So somebody has asked, other than with risk assessments, what issues do people using electronic systems have with prescription and compliance with non-pharmacological thromboprophylaxis? We've been told it cannot be prescribed on the drug chart, but comes under tasks. So stockings and IPC. We were the same. It's taking us a while, but we are still pushing to have those as orderable on the MAR, the medication. Does it stand for? The medication chart.
So for us, we've managed to get all the mechanical prophylaxis prescribable, but they have to come under the section of medical devices and equipment. So it's a bit confusing because it comes under where the wound dressings are in the prescribing section, but we have made it so that you're able to have them prescribed and then documented as administered.
Yeah, it's about finding those workarounds, isn't it, really, to make it auditable as well. Thank you both ever so much. I hope that was useful to the audience, and it's something that I'm sure we're going to be talking about for years to come. So I think the general message that came through very much, though, was that learning from each other is so important, particularly those using the same system as you. Definitely try to find allies on that front. And thanks very much. So we're going to move over now, a bit of a change of theme. Ros and I are going to talk about warfarin management. And obviously we're using warfarin a lot less now. However, we have at King's, I think we still have around 1,800 patients, I think, who are on warfarin. So we're still kept quite busy by these patients. And of course, it tends to be the patients who are less stable and a little bit more intensive in their needs. Sorry, just trying to share and get it looking right on our screens here. So I think that you can see that now. Yeah. Okay, so I'm going to hand over to Ros.
Hi, hello everyone, hope you can hear me. My name is Ros Byrne, I'm lead pharmacist for anticoagulation at King's. So we're just going to do a quick refresher, as Emma says, about warfarin. So warfarin is a drug that probably, I think we all know, wouldn't be licensed today. If there had been any other option, it probably wouldn't be licensed at the time. It has a very narrow therapeutic index, which means that the difference between someone bleeding and someone clotting is not very wide. It works by suppressing the clotting factors 2, 7, 9 and 10. It's highly protein bound, which can sometimes cause issues. It has a very long half-life, which means that it has a slow onset of action, but also a slow offset of action, if that's the right terminology. So it hangs around for a long time. We need an antidote for it because we can't, you can't just wait for its effect to wear off, like arguably you can with the DOACs. We know that it's monitored by measuring the international normalized ratio, which has to be done very regularly for many patients. It's quite labour intensive. There's a lot of INR monitoring and doses being adjusted left, right and centre, which can cause some communication issues with some patients. And then there are a lot of drug interactions associated with warfarin, which mostly I'll come on to a bit later, but mostly can be managed quite easily. But the drug-food interactions sometimes cause patients probably more distress than they need to, because actually I think they have to make quite massive changes in their diet to have an actual effect on their INR, but sometimes that can be an issue. And the whole reason we need to do all this monitoring is because it has unpredictable pharmacokinetic and pharmacodynamic effects. So yeah, a difficult drug, I think it's fair to say. So who still needs to have warfarin? I mean, ideally nobody, but there are, as Emma says, we have got quite a few patients and they're all the tricky ones now. So it becomes, it still is labour intensive. Patients with renal impairment, the creatinine clearance cutoff is usually less than 15 mL per minute, and patients on dialysis we don't tend to give DOACs to, so they generally need to be on warfarin. Although, having said that, we do sometimes use apixaban 2.5 milligrams twice a day in those patients who are on dialysis with level monitoring, but that's a bit niche. Usually those patients end up on warfarin. And we can't give warfarin to patients with AF who have moderate to severe mitral stenosis because we don't have enough evidence for its effect. So that would be valvular AF, as opposed to what the DOACs are licensed for is non-valvular AF. Those with a high thrombotic risk, where their INR target has been increased, obviously you can't give a higher dose of a DOAC, so we tend to make sure those patients stay on warfarin, although there's a bit of wiggle room around that as well. Patients with mechanical heart valves, an absolute no to using DOACs, so we're stuck with using warfarin for those patients, and they tend to be some of the hardest to manage. Patients with antiphospholipid syndrome, again, there's some wiggle room here as well, but patients who have triple positive, so high thrombotic risk antiphospholipid syndrome, must stay on warfarin. Maybe patients with extremes of body weight, again, we sometimes use DOACs for patients we often use DOACs, to be honest, for patients that have extremes of body weight now. But if you're worried about efficacy, then again, you need to be able to use warfarin that you can monitor. That's the advantage of it being able to monitor it or having to monitor it. And interacting medication, which I'll come on to a little later. So before we start warfarin, we're thinking about, is it safe to start it? And this is true of all anticoagulation. Is the patient's thrombotic risk higher than their bleeding risk? Is the platelet count satisfactory? I mean, usually we'd be happy to give anticoagulation to anyone with a platelet count over 50. Do they have liver disease that's affecting their coagulation? So coagulopathy associated with liver disease is usually a reason not to anticoagulate, and sometimes for contraindicating the DOACs if liver disease is particularly bad. And then social factors, which is the big one, isn't it? And the reason we try to put patients on DOACs is because it's a lot easier for people to manage. So if people have a lack of understanding or lack of support to enable them to do the dose changes and the constant monitoring, then we would try and get them onto a DOAC. But so with that needs to be checked. Can they actually manage it before starting warfarin? Always determine the INR range, really important. It's mostly 2 to 3, isn't it, for most indications, but for valves can be higher. And then consider the warfarin loading schedule. Are we going in with high doses and getting their INR range as soon as possible? Do we need to do that? And then do we need to bridge them with low molecular weight heparin whilst we're doing that? This is our warfarin loading protocol at King's, and it's a validated protocol that we've sort of used for many years. We used to have a 10 milligram option, but we got rid of it actually because most people don't really need 10 milligrams of warfarin, even at the beginning. And there's no huge desperation to get their INR in range. People can be bridged, they can go home on bridging if they need to. And we were finding that we were just getting high INRs, probably because it wasn't being monitored well enough. Most patients that start warfarin are quite frail and old now. So it felt like the 5 milligram dosing was enough. And the INR using this protocol, the INR needs to be checked every day for the first 4 days and then adjusting the dose according to whatever the protocol says. And then just bearing in mind that the kind of people that are going to be, I mean, it's sometimes hard to predict and sometimes surprising when people are, quite big and young, that they can be still really sensitive to warfarin. But generally, older patients with low body weight, who don't eat much, who maybe have a bit of liver disease and certainly heart failure, and patients on interacting drug therapy tend to be sensitive to warfarin or can be sensitive to warfarin, and sometimes we'll start on a 3 milligram dose. So in terms of dosing adjustment, I mean, this is one of those things that you get used to with doing it lots, which is a problem because lots of people, especially the doctors on the wards, don't dose warfarin very often. So there are all sorts of crazy things happen with the dosing of warfarin on our wards. But general principles is to try and find out if the INR result is high or low, why it's high or low. Have they missed a dose? Have they taken the right dose? Have there been any changes? Are these changes permanent, i.e. they've started a new diet that's permanent, or transient, they had a few glasses of wine last night, and that will sort of determine what you're going to do. So if there's a permanent change, then you change the dose for the long term. And if it's transient, you might give a booster dose, or, might just reduce the dose for a short time. If their patients have a lower INR, as I said, consider boosting dose. And sometimes we're going to have to think for our high-risk patients, do we need to then start bridging them just until their INR's back in range? And I'll go on to how we treat high INRs, but we generally omit the dose. And I've got our reversal protocol, which I'll show you in a minute. And I think then just the other thing to point out to junior doctors is that the dose adjustments don't need to be massive. And certainly if someone's taking a small dose of warfarin, it's all about percentage dose increase and dose decrease, basically. If they're taking a small dose of warfarin, you don't change someone who's on 1 milligram of warfarin and has an INR of 1.9 and put them on 2 milligrams. You're doing small dose adjustments. Otherwise, you've got INRs going up and down all over the place. So bear in mind the maintenance dose, basically, is what I'm saying. This is our protocol, or an example of a protocol for reversing warfarin, which we reverse with vitamin K. Often the common issue with this is people give too much vitamin K. If a patient's not bleeding and you're literally just reversing the INR, the numbers essentially of the INR, you want it to be back in range rather than completely reversed. 2 milligrams of vitamin K is fine. Sometimes patient gets 10 milligrams because it's in a 10 milligram vial, and then you find it really hard to re-anticoagulate them when the time comes. And we might consider giving a small dose to patients who are high risk of bleeding with an INR over 5. And then patients with major bleeding, we tend to give 5 milligrams of vitamin K, and we also give them prothromblex. That's big now. PCC. We replace their clotting factors essentially. So drug-drug interactions, the good thing about warfarin is that we can monitor it in terms of interaction. So it has an advantage over DOACs in that sense, because when you've got an interaction with a DOAC, a significant interaction, unless you're going to, and even if you do monitor DOAC levels, you don't really know what they mean or what you're looking for. So really, patients need to then switch to warfarin if they've got a significant interaction. So warfarin is this mixture. This is like going back to university days, but there's this mixture of these two enantiomers of warfarin, which is the R and the S, and the S is more potent. So most of the interactions are mediated by this through CYP2C9. So it's those the drugs that also metabolize that route or inhibit or induce that route that tend to interact with warfarin. So these kind of drugs. So the inhibitors are inhibiting CYP2C9 or whatever enzyme, and therefore increasing the level of warfarin in the blood potentially. So they're having an inhibitory effect, but they're increasing your INR. So things like ciprofloxacin, you see sometimes quite a profound effect with that kind of antibiotic or metronidazole. And not so much with penicillins, but with these two particularly. Amiodarone also, you see quite a dramatic effect, and the antifungals, and alcohol works in that way too. And then the inducers that are reducing the anticoagulation effect by increasing metabolism of warfarin. Rifampicin is a particular problem. So when we start rifampicin when patients on warfarin, we're monitoring very regularly and sometimes having to increase the dose from their normal maintenance dose by doubling it or tripling it because it has such a profound effect. And then the anti-epileptics. But the good thing is that you can monitor it, and therefore it doesn't mean that these aren't contraindicated drugs with warfarin. It's not that patients can't take them, it's just that we need to know, they need to communicate with us. That's really important. And then we have pharmacodynamic interactions, so increased risk of bleeding, particularly with antiplatelets, other anticoagulants. We ask patients to avoid taking non-steroidals and aspirin. And then just in terms of the SSRIs, there is an antiplatelet effect from those types of antidepressants. And I don't think we've quite worked out exactly what we're doing, and it tends to be on a case-by-case basis. So I think if someone already has had a GI bleed or has other risks of bleeding or are particularly frail, then we might think of giving them some stomach protection, maybe with a PPI. But most patients don't need it, to be honest. The risk is quite small, but it does have an antiplatelet-like effect. And then there are other mechanisms for pharmacodynamic interactions. Well, vitamin supplements. Some people, you find out, why can we not get your INR in range? And you find out they've been taking vitamin K in a supplement they haven't realised is there for a while. And similarly in feeds. I think sometimes the antibiotic reaction we see is actually due to acute illness rather than the actual antibiotic. And diarrhea and vomiting obviously causes major issues. INRs can, especially in frail people who have an episode of diarrhea or vomiting, INRs can go really, really high and be very hard to get down then. So that's one, I guess, to tell patients to inform us, although that might be difficult if they're really ill. Okay, I think I'm handing over to Emma now.
The headset gets passed on. So naturally, anybody on warfarin at some point, or not naturally, hopefully they won't need any procedures or surgery, but there's a good chance that they will at some point if they're on it long term. Now, if they're on warfarin short term, which doesn't tend to happen very often now, if we have people on warfarin, generally it does tend to be long term. But if they are on it short term, then we would recommend that the procedure or surgery is delayed until they stop it if possible. If that's not possible, then ideally we'd wait until the acute episode has resolved, such as a thrombosis. But again, sometimes that's not always possible. So this is our peri-op management plan. Just a little reminder there, though, to always check your local policy. And so it categorizes the risk of thromboembolism into high and low risk. And also you're going to want to look at the type of surgery or procedure as well and categorize that into high or low risk of bleeding. So for all procedures that have an increased risk of bleeding, we're going to stop warfarin 5 days ahead of surgery. And then if they also have a high risk of thromboembolism, and I won't go through the list there that you can see, then we will consider bridging them with lemrecurate heparin, and we might need to check that they've got up-to-date blood test results to make sure we can do that safely, and obviously help them if they need any help with administering that. And then post-op, we will always write a full elective plan for our elective patients, but with a sort of caveat that it's the reloading phase and the recommencing lemrecurate heparin is always going to be down to the surgical team's sort of clinical decision making, really, depending on the bleeding and how the surgery went. And then importantly, the patient needs to have an arranged next INR. So like Ros said, we ideally get as many of our patients on warfarin, off of warfarin onto a DOAC, even though the studies didn't necessarily show that the DOACs were more efficacious than warfarin. We know that it's much simpler, it's better tolerated, they are better tolerated, I should say. And I think that particularly when you've got a patient who's very unstable on warfarin and their INRs are going very high or very low, I think there's a good argument for improved safety and efficacy on a DOAC. So if you do need to do that, then you would check the INR before switching to a DOAC. If it's less than 2, you can go ahead and switch straight away. If it's between 2 and 2.5, we would usually either start the DOAC that same day according to the patient's risk, or we may wait until the next day. You can always check the drug SPC for the specific INR that they recommend as well. But usually it's between 2 and 2.5 that you can then start a DOAC. If it's between 2.5 and 3, we may get them to omit a day or 2 and then start, but we may possibly get them to recheck their INR, but we'll play that on a sort of case-by-case scenario. If the INR is over 3, then again, if it's only just over 3, we may get them to miss a day or 2 and then start the DOAC. But if it's significantly over 3, we'll want them to stop, and then we'll check the INR before commencing the DOAC. And again, it doesn't happen very often, but sometimes we need to switch from warfarin to therapeutic heparin, either lemrecurate or unfractionated, and then we would stop the warfarin and start when the INR is less than 2. So this is the bit that we're sort of glad that we don't have to do on a very regular basis now, not because we don't enjoy it, but just because it's very time consuming, the whole patient education and counselling of warfarin initiation. It's such an unusual drug, and if patients have never come across it before, it takes a little while sometimes for them to get their head around it. Obviously, it's a high risk drug, so there's a lot we want to tell them about their own safety and what to do in the event of any bleeding. There's a lot of information listed on the slide there. But I think the really important thing to note is to adjust it to your patient. So the patient sitting in front of you, perhaps they're hospitalised and very unwell and not really going to be able to take on board a lot of information at that time, in which case you tell them the headlines, you give them the written information, and then perhaps arrange a follow-up. So you'd tailor it to the person sitting in front of you. But obviously when I talk about the headlines, they really need to know the risk of bleeding, and they really need to know how to take warfarin safely. So once they leave hospital or once they leave your clinic, you need to be confident that they know what dose to take each day and where to get more help. We issue all patients with the anticoagulant alert card that you can see there in the right hand corner, which will have the clinic details on so that they can contact us if needed. Now, increasingly, we are encouraging and supporting self-monitoring. We have about 300 patients across our sites here that self-monitor INRs. Unfortunately, we can't fund the machines, and they're sort of around 300, I think a little bit more than that now, pounds each. So the patient does need to be able to buy their own machine, but it's just such a lifeline for patients who perhaps have poor venous access or are needle phobic or have got a busy work or family schedule and are unable to get to the hospital to have regular blood tests. So we support people and we train them to use the Coaguchex, and that is the system of choice from NICE, the Coagucheck XS. There was another one that they recommended, but that isn't produced and manufactured anymore. So considerations, we switched an awful lot of people to self-testing during the COVID pandemic, and we did some review on how they got on, and we did find that when patients were carefully selected, their time in therapeutic range improved, the DNA rate reduced, and the patient satisfaction went up enormously, as you might expect. But we did really learn that careful selection is so important. Some patients are not necessarily all that self-aware either, so they would tell us, yes, I'm going to be able to do it, and we get them into hospital to teach them and realize that their eyesight was perhaps very poor, or they had very poor manual dexterity and weren't able to actually take the test. The strips are quite expensive, so it is a consideration if it's going to be somebody that requires several attempts each time to be able to take the test, then that becomes quite an expensive method of INR testing. So the patient needs to commit to adhering to the testing schedule. And like I say, there's a fine line there. You don't want to exclude people who historically have DNA, because actually it can have a really positive impact on their DNA rates. But you need some sort of assurance from the patient that they are going to adhere to the testing schedule, and that they're not going to test an awful lot outside of those tests as well, which can sometimes be a problem. They need to communicate their results on the same day that they take them during office hours, so that we can dose them on that same day. And we need to, there's varying evidence with regards to antiphospholipid syndrome. Some studies have been published to show that actually the effects on the INR through a Coagucheck machine are not significant, and others have concerns around false high readings, particularly in the context of lupus anticoagulant. So what we tend to do, if our antiphospholipid syndrome patients want to consider Coagucheck testing, we tell them about that. But if they would like to go ahead, then we ask them to do at least 3 correlation tests, where they would come in and have a venous test the same day as their Coagucheck. And obviously if they all came in within a close range of each other, then we'd be happy to continue that. But the patient would have to take that on board, knowing that there's a chance that that may not be effective for them. So it is challenging. As Ros pointed out, it's an unpredictable drug. There are many, many variables that can interact with warfarin management, and sometimes patients who are doing their very best and get very frustrated because despite their best efforts, their INRs can become quite unstable. We have to think about supporting patients through lifestyle changes. We notice an impact on the INR sometimes through times of great emotional distress, and maybe that's down to maybe their oral intake, the amount that they're eating, but I suspect that there may be some or other mechanism that can affect the INR when people are extremely stressed and upset. We have to support people when they travel abroad, and in our cohort of patients, sometimes people will travel abroad for many months at a time, so that has to be taken into consideration, and we need processes to make sure we can do that safely. And actually linking quite nicely with our previous talk about electronic systems, integration sometimes with the warfarin dosing systems and the general electronic systems in the hospitals is not very good. We don't always have an interface. When we switched to Epic, we actually switched from a dedicated anticoagulation software to using Epic for all of our warfarin dosing, and it was extremely challenging and remains challenging in some ways, but the huge benefit is that the rest of the hospital and in fact the wider healthcare community can see all of our INR tests and our dosing and all of our notes, which has a big impact, I think, on patient safety. So bit of a whistle-stop tour there on the basics of warfarin management. I hope you enjoyed that. I'm just going to have a little look at the questions. Do DOAC alter INR, how to interpret this for interventions. Yeah, so that's a difficult one. What I would say is that yes, they can affect the INR, particularly rivaroxaban, but they don't necessarily affect it in any sort of reliable way. So I think it's good to look at the INR if you're wondering if somebody has had a DOAC or not, but that it can't be relied upon. You can't say, oh, they've had it within the last 12 hours because the INR is this. What would you add?
It also depends on the reagents your lab uses. So some labs it won't be sensitive to, so it won't affect the INR, and some it will. So it's kind of a local thing. But yes, it's almost not worth looking at it in a way because it doesn't really mean anything. Might just tell you they're on it. That's all.
Yeah, which can be helpful in the emergency department if someone comes in with a stroke and you're wanting to consider thrombolysis or something. Claire.
Yeah, thank you both. I was going to come in on the DOAC, the issue there. Switching from a DOAC to warfarin is so complicated because of the interaction with DOAC and INR because of the reagents we're using. And we actually have to switch quite a few people back to warfarin. We're seeing that on a regular basis. And it's difficult, particularly when you get ready to stop the DOAC and then your next INR is subtherapeutic. So there's lots of things there to consider, but it is difficult to do for sure.
Thank you, Claire. We're just looking through the questions. Someone's asked, can we use low molecular heparin for mechanical valves? Which is a good question.
Yeah. Yes, we do. We were using unfractionated heparin immediately post mechanical valve insertion, but we managed to persuade our cardiothoracic team to switch to using enoxaparin after a few errors, shall we say. So yeah, for bridging, we use low molecular heparin. They kind of wanted us to use 1 milligram per kilo twice a day for enoxaparin, so sort of higher dose than you'd normally use. I guess because these patients are more high risk, and that's what we tend to do. But yes, you can.
Thank you. Yeah. And somebody's asked regarding self-monitoring, how often do you recall patients for quality control of their machine and checking technique? Another good question there. So we don't recall them for QC of their machine because it all had those little excess machines have internal QC, and we don't check their technique. It's very difficult to get a reading if your technique is incorrect. It will generally give you an error code. As long as patients know the basics about washing their hands beforehand and making sure they're thoroughly dried. But we do get them to come every 6 months to do a correlation test. So they will have to come and do a coagi check on the same day as a venous test so that we can be sure that it's still reading effectively. But we do see some variation though between those two readings, and then the difficulty is, well, what do you do when you're faced with that? Generally we would ask them to do it again. If we had a variance of more than 0.5 in the INR between the two readings, we'd ask them to come back again. If that persisted, we would get them to perhaps contact the company that they bought their machine from and to get it checked. But it is really difficult. Obviously, once they've started doing that, they're going to want to continue. So a little bit difficult to manage. Thank you. I can see that we're out of time, but thank you. I'm sorry that we didn't get through all of your questions, but I'm really pleased actually that it has generated some interest and some questions because there's still so much work to do, and these are still quite challenging patients to manage. So thank you so much for all of my speakers that have joined today. Thank you again to Jo Jerome for the wonderful work that you do with Thrombosis UK in this fantastic conference that we're all learning so much from. And thank you all for joining today and for your time and input.